nearby nerve fibers, or they can have distant communication. And treatment focuses on interrupting this communication, whether it's up close and personal, or you're blocking the secreted, either blocking secretion or their target on the nerve fibers, and potentially on the surrounding connective tissue as well. There are plenty of mast cell receptors. Mast cells are really designed to identify various substances. And then also there are communications between the nerve fibers and the mast cells, which will cause the mast cells to degranulate. So as I shared with you, I have cold-induced urticaria. We have some people who have pressure. Certain chemicals that get released can also cause mast cells to degranulate. If you have an autoimmune disorder that's kicking out certain types of chemicals like interleukin-33, you can cause mast cells to either increase in number or activity as well. And then you can also see that there are chemicals derived from nerve fibers that can also cause mast cells to become dysregulated. This is just a summary slide showing you all the different ways mast cells can be upset. Mast cells were originally designed to recognize parasites, viruses, certain bacteria, whether or not there's any physical trauma. The communication can happen with nerve fibers, the surrounding connective tissue, or nearby inflammatory issues. But once these cells are activated, depending on what they see, they'll call in whatever necessary help. It's kind of like that. If they see somebody down, you don't need to call the SWAT team, you need to call an ambulance. If these mast cells see what they think is a parasite, they'll call in eosinophils. If they think it's a bacteria, they'll call in neutrophils. Or they might think they need a job by themselves. You might not see any infiltrate. You might not see any inflammatory cells whatsoever. And by the way, unless you have special stains for the mast cells, you can't see them. You really need to ask the pathologist. You have to have stains that target the mast cells themselves. Again, lots of different symptoms and signs that are associated with mast cell dysregulation. Medications that are typically associated with mast cell activation disorder to try to get it under control include medications that target histamine, including histamine blockers, and we have H1 blockers such as Benadryl and Zyrtec. We have H2 blockers such as those that are used for reflux, including Tagamet, which is cimetidine or ranitidine and famotidine. Steroids are tried and true. However, some patients can't tolerate certain forms of corticosteroids, and by the way, not all medications work the same in individual patients, so it's really important to tailor the therapy. Tricyclic agents actually work on the first, second, and third histamine receptors. Leukotriene blockade, most of you know MCAS or Singular. There are 2 other medications that also work on that pathway as well. Mast cell stabilizers, including catodafin, as well as cromolyn or omalizumab. It has been indicated in this country for 13 years for the treatment of asthma, and 2 years ago it just got indicated for chronic hives and urticaria. And then as far as laboratory testing, again, you can check your serum tryptase, and sometimes you need to check the serum tryptase more than one time. So if it goes up 2 plus 20%, that's indicative of you having a mast cell activation disorder. You have prostaglandin or histamines in the urine that might indicate that your mast cells are overactive. You may have abnormal looking mast cells in the tissue, and you need to stain them with these molecules to identify whether or not they're chronically activated or not. And then to light up the mast cells themselves, you either have to use a CD117 antibody or a c-KIT antibody, which is a major receptor on mast cells as well. So you think you might have mast cell activation disorder, and I'm not going to go through all these conditions, but these are conditions that mast cells are involved, but not necessarily a primary mast cell activation disorder. It's really important to sort that out because there are other treatment modalities and diagnostic modalities that need to be identified to make sure that there's not another condition that's contributing to your symptoms as well. So what do we know about mast cell? And monoclonal mast cell activation disorder, you also have sustained mutation in the c-KIT gene, but it doesn't cause such a profound syndrome as mastocytosis. This is what's more common, and what I look for when people come to my office is I'm trying to understand, do you have these other things going on that may be contributing to your mast cells being dysregulated? And for the folks here, These physical urticarias, this is a conversation between your mast cells and your surrounding connective tissue. And then, if I can't find this, and I can't find this, I'm an idiot, I can't figure out what's going on, so you get tossed into the idiopathic. Again, lots of different disorders. Mast cell activation disorder, mastocytosis means you got too many mast cells running around. Secondary or idiopathic mast cell activation disorder means you have the same number of mast cells, they're just in overdrive, they're doing overtime because of some other disorder. Again, this is a child that came to me. This is an isolated mastocytoma, so if you biopsy this, he has more than 80 mast cells in that one lesion. This is a more diffuse version of mastocytosis as well. This is a young lady who came in for allergy testing. As you can see, she has a little bit of hypermobility in her elbows. But more importantly, you see this is skin testing. Her reactions were much more prominent when I skin tested her. So there's, again, some type of conversation that's going on between the mast cells when they have connective tissue disorders. This is just looking at pathology, so I'll save that for the pathologists in the classroom. This is another mastocytoma, and you can see, remember I was saying that mast cells don't like being clustered? This is what it looks like under the microscope, and that shouldn't be. It should only be like one or two in the field. Lots of different cells crosstalk with the mast cells, whether or not they're nerve fibers, lymphocytes in the area, fibroblasts, as well as eosinophils. I want to identify that if you have chronic hives or urticaria, it's really important to identify whether or not you've developed an autoimmune response attacking your mast cells, which would mean you have now a mast cell activation disorder as well. I have to tell you, and this is kind of an issue about healthcare, if you have a nose problem, you go to an ENT. If you have a skin problem, you go to a dermatologist. If you have a headache, you go to a neurologist. Everybody kind of sticks to their own little corner of the sandbox and doesn't think outside of the box. So it's really important to kind of think, well, I've tried all these things, it's not getting any better. You need someone who's going to take a step back and a little bit more of a thorough history. Okay. So I just wanted to, I'm going to fast forward a little bit. I have to tell you, my first introduction to connective tissue disorders outside of my internal medicine board exams many moons ago, I went to Dr. Google, and I came out whether or not Ehlers-Danlos was the key to understanding connective tissue disorders. And for me, it's more along the lines of, is Ehlers-Danlos the key to understand how mast cells become dysregulated? And he started talking, as Dr. Henderson had alluded to, there are certain breeds that have a tendency to have connective tissue disorders. Interestingly enough, those breeds also have food sensitivities, leaky gut syndrome, eczema. And so there's something going on, again, with this crosstalk between the connective tissue as well as the immune cells that are situated in the connective tissue, that being mast cells and also dendritic cells. This is a very old article, I shouldn't say old because I'm dating myself. Dr. Castori, a lovely geneticist out of Italy, put this article together looking at different data trying to understand what's associated with joint hypermobility syndrome. And I'll leave that to the other working group on defining Ehlers-Danlos hypermobility versus benign joint hypermobility versus joint hypermobility syndrome. However, he talks about immune dysregulation in addition to chronic pain syndromes, chronic fatigue, but he doesn't elaborate what that immune dysregulation is. And that's essentially where we are right now when it comes to trying to understand what does mast cells do in individuals that have a connective tissue disorder such as EDS or joint hypermobility syndrome. On connective tissue, there was one paper coming out of Siberia that identified individuals who had an eye surgery, and interestingly enough, the individuals that were found to have a form of connective tissue disorder, the number of mast cells were the same, kinase was upregulated in those patients. And again, Dr. Milner identified individuals that have a mutation in the tryptase molecule. He identified this in 3 generations in several families. If you have an elevated tryptase, you are at increased risk for having hyperextensibility as well. So again, the questions that we need to address is what's going on between all the cells that are sitting in your different organ systems. You know, what's the crosstalk between the mast cells and the fibroblasts and the nerve fibers? And is this conversation, you know, quiet, or is it the Tower of Babel, causing you to be quite symptomatic? So going forward, what we really need to do is try to understand this crosstalk. Are these cells, and I have to tell you, I've seen individuals that have mastocytosis, and yes, there are issues with their connective tissue. And even in that little boy that I pointed out to you, who has mastocytosis in his skin, he has respiratory issues, he has gut issues, but they're not increased number of mast cells that are in the tissue. That the mast cells in his skin are secreting factors that are upregulating his other organ systems as well. But we need to understand whether or not abnormal collagen metabolism is causing mast cell dysregulation, or is mast cell dysregulation causing abnormal collagen metabolism? And, you know, it's a question of which is the chicken and the egg, or is it both the chicken and the egg that's causing the patients having those issues? I have to tell you, this has been a journey, and I am extremely grateful to this foundation, as well as my colleagues.